I'm Benji Ozynski. I'm a medical doctor by trade. I'm involved in a few healthcare ventures in the business side, but my main passion and profession is I'm a sleep medicine doctor. I work at the Sleep Health Centre South Africa alongside Dr. Alison Bentley, and we cover and manage the broad range of sleep disorders. We work in sleep optimization and we do everything sleep.
I think our audience is highly aware of the importance of sleep. When people come to me as a nutritionist and they say, what is the best thing I can do to lose weight? And the first thing I say to them is get enough sleep. They look at me and roll their eyes, but it's true. So let's start with some of the most common questions. Is 8 hours of sleep what's needed to live well, live longer, be healthy, and rest?
So not necessarily. When we look at 8 hours kind of sits in the middle. So, when epidemiological studies are done, it takes thousands or hundreds of thousands of people and it maps out the average across the population. And we generally say that for a healthy adult, the average duration you need is between 6 to 9 hours. Generally speaking, anything below 6, we would look at that as a potential sleep disorder, and likewise, anything above 9 hours. Now, it greatly varies, that 6 to 9 hours. There are many people who, with 6.5, 7 hours feel great. There are other people who need more, but it's definitely a misconception where people are chasing that 8 hours of sleep and not getting it, despite not having a sleep disorder and despite feeling really good during the day.
So would you say then that it varies depending on your time of life? So it's said, and I don't know if this is true, that people who are older, so people in their 70s and older, probably need less sleep, or is that a function of aging, whereas kids need more sleep?
100%. So it really depends on the age group that you fit into.
Okay.
So obviously, all the way from babies to toddlers to teenagers, it varies. And obviously, on the lower end, of life, you need more sleep. And then, we talk about healthy adults, let's say from about 18 to 21 to about between 55 to 65, depending, on the type of person. And generally, the elderly patients, that range shifts from about 5 to 8 hours. And so absolutely people over the age, of 65. And I see a lot of patients, postmenopausal women, elderly patients who come to me and they say, I just can't sleep like I used to. And I say, well, you're not supposed to. So as one ages, one's requirement for sleep from a duration perspective reduces.
Okay, so if I come to you and I say I'm not sleeping like I used to, and you tell me it's because you're not supposed to, but I say, but I'm not feeling energized.
Yeah.
Then what?
So one of the most important markers as sleep medicine doctors we use to assess your quality of sleep and your duration of sleep is how you feel during the day.
Okay.
And at any stage of life, if I get a patient or someone who comes to me and says, I'm really not feeling good during the day, that is when we take a look and that's when we do an assessment.
Right.
Yeah.
Okay. So how about people who come to me, and I work with people who we try and get their sleep right all the time. And they say, well, I go to bed at midnight and I sleep until 8. So I'm still getting my 8 hours, but I'm still feeling tired. Is there a circadian rhythm reason reason why we need to get to sleep at a certain, point in the evening before, say, midnight, and not let it go over into the early hours or the later hours of the morning?
Yeah, so it very much depends. I think the first thing to note, again, approaching this as a sleep medicine doctor who's, we manage clinically significant sleep disorders all the time. So, step number one, if someone comes to us and they report, sleeping an appropriate duration, a good duration for their age, and that they're feeling like their sleep is unrefreshing, we would first look to rule out medical disorders, we'd look to rule out mental health disorders, and we'd look to rule out sleep disorders as well. There are quite a few sleep disorders where people present with having a good amount of sleep, but they just feel tired and sleepy during the day, and they wake up feeling like their sleep wasn't refreshing. And so that's kind of on the medical side of things. So we work to either rule out or diagnose and manage various sleep disorders that can result in what we call excessive daytime sleepiness.
Right.
From a circadian perspective, it's quite interesting. So it's something called a chronotype.
Okay.
So largely speaking, there's two groups, night owls and larks. And this is actually genetically driven. And so, I always ask people, let's say, you were in varsity or you were in school and you had to cram for an exam. Are you the type of person that would stay up late to study? Or like me, I would rather go to bed early and wake up at 4 a.m. and that's when I felt most fresh.
Right.
And that's actually genetically driven. And it's got to do with when your body and brain release cortisol and melatonin respectively. And we see that in night owls, your alertness and your cognitive functioning starts off quite low and it increases throughout the day and gets better as the day goes on. And then right at the end of the night, it dips. Whereas we see in larks, it has a kind of like a curve like that, where they feel most productive in the morning and then it starts to dip. Like for me, my brain shuts off at 7 p.m.
Mine shuts off at 2 p.m.
Yeah.
I can do nothing, but I can get a lot done at 6 a.m.
Exactly. And that's very difficult to change.
Yeah.
And so, one has to, and it's kind of intuitive, are you a night owl, are you a lark? And you want to kind of, as much as possible, practically speaking, work with that. And so your night owls can go to sleep at 11, 12, wake up later, and that's great. That's when they feel most productive. And then, the larks, people like us, we want to be in bed at 9 p.m.
At least.
Wake up at 5, and then, we're good to go.
Yeah. So what happens when, and I'm speaking for myself and a lot of other women, when you get into perimenopause? Why do you start waking up earlier and earlier in the day, no matter what time you went to bed the night before?
Yeah. So the perimenopause is a super interesting space. So if we look at perimenopause, there's actually a lot that results in sleep disturbances. So number one, there's a decrease in the production of estrogen and progesterone, and both are really important in sleep regulation. So estrogen works to block wakefulness in the brain, and progesterone almost works like a natural sedative.
Yeah.
And once those levels start to decrease, women are more prone to having sleep disturbances. The second component is vasomotor symptoms. And even in women who don't experience vasomotor symptoms during the day, they can happen at night. And what happens with sleep, if we divide sleep into two categories, the first phase of sleep is deep sleep. And that's really where, it's difficult to be woken up by environmental or physical stimuli. The second part of sleep, as your sleep pressure clears, is a lot more vulnerable to, things that can disturb your sleep, like temperature, like glucose levels, like vasomotor symptoms, where, and for the audience, a vasomotor symptom is like hot flushes.
Okay.
And so you're a lot more sensitive to temperature fluctuations in that second component of your sleep. And I see a lot of patients, who experience that. The final component, which must be mentioned, is as women get older and go through that perimenopausal period, they are more prone to developing sleep disorders.
Yeah.
So if we look at restless leg syndrome and periodic limb movement disorder, they become more prone to that. Sleep apnea, obstructive sleep apnea, they become a lot more prone to that. And in fact, we assess postmenopausal women at the same risk as men for sleep apnea.
Interesting.
And so if we look at all of that, in the perimenopausal period, for a lot of women, sleep kind of derails. And it can be one of those factors or it can be all of those.
Wow. Okay.
Yeah.
Can we dig more into sleep apnea? Because as I understand, it's something that affects people who are overweight, people who have some kind of obstructive breathing issue during wake hours anyway, so sinus issues or shape of the palate, shape of the nose. How does sleep apnea affect women in menopause where they didn't have these issues before?
Yeah. With sleep apnea, right? Ultimately, what is sleep apnea? Sleep apnea is the collapse of the upper airway on itself when breathing in, okay? And there are a multitude of causes that can result in that collapse of the upper airway. Fat deposition, and in men usually deposit fat, around the neck, which is why they are more at risk. But in postmenopausal women, and anyone who ages, in fact, on the Stop Bank questionnaire, one of the scores is for age above 50, because there's also muscles in the upper airway, and there's muscle, your tongue is a muscle.
That makes sense.
And as one ages, one's muscle tone, unfortunately, decreases. You get more floppy everywhere, including in the upper airway.
It's interesting.
And so if you're having global, muscle tone decrease, you will have that in the upper airway as well.
Okay.
And that results in a higher risk for obstructive sleep apnea.
Okay. So if you don't snore, can you still have sleep apnea?
Of course.
Okay.
So, one of the things in med school that we always taught is that patients don't eat textbooks.
Yeah.
And look, it is very rare because with snoring is ultimately caused by turbulent airflow, right? So it can be caused by structural abnormalities in the sinuses, deviated septum. It can be caused by sinus inflammation, and it can be caused by a narrowed upper airway, right? Where air goes from a wider space to a narrower space. And so what I always say is not everybody who snores has obstructive sleep apnea. The vast majority of people with obstructive sleep apnea do snore. And so snoring is kind of a first indication that one may have obstructive sleep apnea, but it definitely can be caused by other things and exacerbated by other things, like, for example, reflux as well.
Yeah.
Yeah.
I think that makes sense. So if sleep apnea is stopping breathing while you're sleeping, how does that affect the heart, the brain, the vascular system?
Amazing. So many ways. So you have to understand that when you are sleeping, your parasympathetic nervous system, so your rest and digest, part of your autonomic nervous system, is dominant. Okay. And when one has an apneic event, what happens is the following. So the airway closes on itself. Oxygen starts to drop in the blood and carbon dioxide starts to increase. That causes the brain to panic. So hypoxia, right? Or hypercapnia, or both. Okay. Hypoxia is low oxygen, hypercapnia is increased carbon dioxide, and your brain almost gets a mini fright, if I can put it like that.
Yeah, makes sense.
And your brain will wake you up just enough to regain muscle tone in the upper airway, start breathing again, and then you fall asleep.
Right.
And that's what we call a micro-arousal. So you don't remember these wake-ups. Now, the pathophysiology of obstructive sleep apnea and the complications thereof is from, number one, reduced oxygenation when you're sleeping, okay? When, you are recovering and your body is in repair mode. The second component is the increased sympathetic nervous system activation when you should be in the opposite.
Okay.
And so we see people with OSA often will have high blood pressure in the morning because of this constant sympathetic nervous system activation, vasoconstriction, so blood vessels constricting when they should be relaxing. So that constant sympathetic nervous system activation has got complications. The third component, which is quite interesting, is actually structural changes in the thorax. So if you are breathing against a closed valve almost, right, the negative pressure, or the kind of the suction pressure in your thorax increases tremendously. You have to remember your organs, like your major blood vessels, your heart, your lungs, are very soft. And so it's hypothesized that, people who develop arrhythmias, so like atrial fibrillation as a result of sleep apnea, it's hypothesized that a component of that's actually from the changing of your organ's shape.
Wow.
Okay.
Okay.
And then the final component is the metabolic consequences that occur as a result of constant sleep disruption. Okay. And so that is, number one, increased calorie hunting.
Yes.
So if you've had a bad night's sleep, unfortunately,
sugar and caffeine.
Sugar, exactly. And the second component is willpower. So if you've had a bad night's sleep, your willpower is deteriorated. We always used to joke, like, after a call, don't do online shopping because your willpower is decreased. Fat metabolism changes. Insulin sensitivity reduces. Your hunger hormones go in the wrong direction, right? So, ghrelin, the hunger hormone, increases, leptin decreases. So if you put all of that together over an extended period of time, obstructive sleep apnea, people always come to me and they say, I don't breathe during my sleep. Am I going to stop breathing in my sleep? And I say, no, not immediately. You're not going to. So don't worry. You're not going to
you're going to just die.
You're not going to die in your sleep. But there are real complications of untreated obstructive sleep apnea because of all of those mechanisms.
Yeah. Over time, it's going to affect your heart. It's going to affect your brain.
Yep.
Everything's going to take a hit.
Yeah.
Yeah. Would you say that it might be a precursor to dementia?
So, this is a...
I just thought I'd throw that in.
Yeah, it's a very interesting topic. So, I mean, absolutely, disrupted sleep, increases the risk of any neurocognitive condition. The complications, as we spoke about, the knock-on effects of sleep disruption being you don't want to exercise as much, you're going to eat unhealthily. All of those knock-on effects as well definitely, would lead to an increased risk of having a neurocognitive decline. In your maybe not so later years.
Yeah, not so late.
Yeah.
So there are many ways we can try and force ourselves to get to sleep. We'll get to the good ways later. But I mean, my parents were always of the generation that a whiskey or a cognac is what you needed to go to sleep. And we know this is so detrimental. What is the problem with using alcohol to relax and to fall asleep?
Yeah. So, number one, from a health perspective, it used to be said that one glass of wine is good. It's not.
It's not.
Okay. So no alcohol is better than any alcohol.
Yeah.
Okay. That's number one. I think Andrew Huberman said that.
He did.
So I don't want to steal his thunder.
It's okay.
From a sleep perspective, so alcohol obliterates sleep, and it does it in three main ways. So I think it's important, any sleep aid that's used, okay, that causes sedation, that's a sedative. One must understand sedation does not equal sleep.
Yeah.
They are two very different things. Sleep is a highly coordinated biological process that happens, and a highly coordinated central nervous system, brain process, right? Where everyone's kind of heard of light sleep, deep sleep, and REM sleep.
Yeah.
And you cycle through those. And it's important to get enough of each stage. Each stage is very specific in terms of the health benefits it provides. With alcohol or any sedative, that sedation is not the same as cycling through the relevant sleep stages.
Okay.
And in fact, alcohol causes sedation, which does not equal sleep. We now know that. Alcohol obliterates REM sleep. Okay. And so it prevents you from going into REM sleep. The other thing that alcohol does is, and many people experience it, is it causes a premature wake up. So as your liver starts to metabolize that alcohol, you almost have this rebound, hyperarousal. And so alcohol gives the illusion of assisting with putting you to sleep, but it's actually just brute forcing sedation over your brain. It then carries on to reduce REM sleep dramatically, disrupt sleep architecture. It causes a premature wake up. And again, alcohol is really good in the short term in its anxiolytic effect. So reducing anxiety in the short term. The price you pay for that, over and above all the negative effects of alcohol, which we know, is in a lot of people as well, it causes rebound anxiety. So people call it hangxiety. And that's also a component of premature waking up. So my advice is stop the nightcap.
What about cannabis and CBD oils? And I've had people come to me and say, try the CBD oil. Well, I tried it once. The last thing I could do was sleep. It works differently with everybody. And why? What are your thoughts? Just broad scale thoughts on CBD and cannabis.
Yeah. So look, personally, I'm not a fan of CBD. I don't think it does much. Okay. Really and truly. And the research supports that. But again, I get many patients with insomnia who come to me who have been on CBD. And if it worked, they wouldn't be coming to see me.
That's it.
And THC, once again, sedation, but obliterates REM sleep. And if you speak to people, and I've had a lot of people who I discuss this with, they say, that's really interesting because on the nights that I've used alcohol or THC, any kind of cannabis product, like I don't dream. And then what happens is on the night that they stop that or they don't use it, they have these massive, vivid dreams. And that's really your brain trying to catch up on REM sleep because it is so crucial for your overall functioning to the extent that, in people who stay up late, and it's happened, with military personnel, people start hallucinating after an extended period of time awake. That's your brain forcing you into REM sleep because it is so important. And so the chronic use of any of these substances disrupts sleep tremendously.
So while we're on the subject of sleep aids, sleeping pills, I'm a fan of sleeping pills when they're used appropriately. I've been using Stilnox on and off for 20 years, but on and off. I think that's the key. Can we break down what these products are, how they work, where they're used appropriately, where they're not used appropriately?
100%. So if we look at now pharmacological agents that get used to assist with sleep, so I'll break them down into categories and discuss them. So, number one is the benzodiazepines, right? Everyone's heard of one of them or many of them. I think everyone kind of knows about benzos, right? Dormanoct, Urbanol, Xanax, all of those types of medications. So they get prescribed for sleep and for insomnia. And again, I'll talk through, the good and the bad. So, the good with benzodiazepines is a lot of them have got also anxiolytic effect. And so if used in a period of high stress, a not long-term period, but a short-term period of high stress, no problem at all. However, benzos disrupt deep sleep and REM sleep. So you have to understand it's a way up.
Crazy.
And I got asked a question, is a, sedative-induced sleep better than, non-sedative sleep? I said, absolutely not. Natural sleep is best. But a sedative-induced sleep is still better than no sleep. And so it's that way up. How severe is this period for this person? Is it chronic, or is this a short-term acute period of stress going on? So the benzodiazepines get used a lot, disrupt REM sleep, disrupt deep sleep, and do have addiction risks.
Yeah.
We don't see that very often, I must be honest, but it's important to note. We then move on to the Z drugs. So Stilnox, or Zolpidem, Zopiclone. In the US, it's called Ambien. They're a bit better in terms of sleep architecture. So deep sleep, they don't disrupt it too much. REM sleep a little bit, but a little bit better. They can cause complex sleep behaviors, though.
They can also cause late night shopping behaviors.
Well, there you go.
We'll get into that.
100%. And so, again, do not take it for the first time on a plane, because there's a lot of stories of people doing crazy things on a plane. We then look at antihistamines. So kind of your first generation antihistamines that can also be used. Some of them are over the counter as well. So like Somnol is a classic one. And they really block REM sleep. Okay. So again, all of these are causing sedation and not sleep. And then the other class of medication that we see that gets prescribed are antipsychotics at a low dose because of their side effect of sedation.
Trazepam.
So we look at more quetiapine and olanzapine that get prescribed for sleep. Low dose for its side effect, not its actual use. And I think, some people get prescribed that because, those can be used long term. And then the final one is your, older generation antidepressants and anti-anxiety meds like trazodone and trepoline that also get used for long-term sleep issues. So those are kind of the broad categories. And I think it's important to note that if somebody is having insomnia or struggling to sleep, it's important to understand, is this acute or is this chronic? Okay. The second component is, the way I talk about sleeping tablets is, number one, we start with the end date already locked in. Okay. The second component is that it's on top of a program of CBTI, cognitive behavioral therapy for insomnia. Okay. They are taken only when you feel sleepy, so that you don't form a dependence on it to get sleepy.
Right.
And you understand that it is a tool. It is not a silver bullet.
Yes.
And so it's really important to prescribe it responsibly, because what happens with all of these medications, you build up a tolerance.
Yes.
Okay. And again, I get so many patients who come to me who have built up a tolerance to 1, 2, 3, 4 medications that then get stacked.
Yeah.
And the underlying problem has never been solved.
Right.
And again, is it a problem to every now and again take a sleeping tablet when you're having a bad night? Absolutely not. Is it a problem when, you're going through, a traumatic time period, a stressful time period? Is it a problem to take it for a week or 2 or 3?
No.
Absolutely not. Is it a problem to take it for 6 months and then you need 2 of them and then you add another medication? That is when it becomes a problem. Yeah. My analogy always with sleeping tablets and insomnia is like, tearing a ligament in your knee and then getting pain tablets. It treats the symptom, but unless you fix the underlying cause, you not only will become tolerant to the pain medication, you'll need, a lot more while the cause of the problem still remains.
So what are the most common underlying causes you see in your clinic for insomnia?
One more that I have to add to the medication is a new class of medications, and they are called DORA drugs.
Yes.
So DORA stands for dual orexin receptor antagonist. Very, very different. So the one we get in South Africa is called Dayvigo, lemborexant. And those medications, the DORA drugs, are good in the sense that they're not sedatives in the traditional sense. So they're not working on histamine pathways or GABA pathways. They block orexin, and orexin is a neuropeptide in the brain that causes wakefulness.
Right.
And, it's been seen before that, in the pathophysiology of insomnia, there is kind of upregulation of orexin. And so DORA drugs like Dayvigo here, they block wakefulness. So they antagonize orexin receptors and they block wakefulness and allow natural sleep to occur. They're not sedatives. And so, again, I get a lot of people saying, well, I've take Dayvigo, nothing happens. Yes, because you're not doing CBTI and you're not doing it in the right way. And so that's kind of the newer class of drugs that we have available. Yeah.
That's so interesting, especially it sounds like that would be a lot healthier or a longer term approach for people who are, I think, let's go back to what are the causes and see which drug would possibly fit the pathology.
100%. So if we look at chronic insomnia as it's defined in the DSM-5, as most conditions in the DSM-5, which is a psychiatric manual, you kind of have to rule out other causes, right? So again, if we take insomnia, let's say we've ruled out medical conditions. There's a lot of medical conditions that can be causing sleep disturbances. We have to investigate and rule out mental health conditions, right? We have to look at substances, okay? Medications, certain type of medications. So kind of once we've cleared all of that and we're dealing with a classic insomnia case, the cause of it goes like this. There's 3 stages to developing chronic insomnia. So the first is predisposing. Some people are just predisposed to getting it, others are not. The second stage, and this is where I think, sleeping tablets have the most are most relevant, is the precipitating stage. So something happens for a period of time that acutely disrupts somebody's sleep. So that can be a medical condition. That can be just a really stressful time period. Any cause, there's a multitude of causes of stress. It can be a tragedy. So anything that for a period of time disrupts your sleep. In that predisposed brain, your brain forms the wrong association with your bed, where previously your brain would subconsciously associate your bed with sleep, restfulness, and sleepiness.
Yes.
A switch flips and it forms a pathological association that bed equals awake and bed equals anxiety.
Yes, I think it's very common.
Yeah. And our brains can't differentiate between different types of danger. So for example, if you're really panicking about, a meeting or a presentation, or you see a saber-toothed tiger in the bushes, your brain actually can't differentiate. And so in somebody who's going to bed, who's tossing and turning, freaking out about something, or, is bedridden and they, spending extended period of hours in bed, your brain learns that this place is a place of being awake and of stress.
Yes.
What then happens is, that precipitating period resolves.
Yeah.
So, you work through your trauma, the stressful period ends, your medical condition, your mental health condition, whatever gets resolved. But you are left with persisting insomnia, and that's that pathological association that's formed.
Right.
And so you can see then how sleeping tablets in that persisting insomnia stage are not going to do anything.
Yeah.
They will work temporarily by brute forcing sedation over your brain. But that pathological association, and there's so many parts of the brain that are involved in that, still remains. And that's really where CBTI comes into play, cognitive behavioral therapy for insomnia comes into play, that works to actually treat the cause. And so, it's not a hard and fast rule that we won't use sleeping medication in the persisting stage. There are some people who really need it. But definitely in the precipitating stage, it can be used. But again, CBTI in either one of those scenarios.
Interesting. So many people say when they just go sleep in another room, they're fine. Or they change sides of the bed, they're fine. And that makes so much sense, because if you're associating that particular space and time with anxiety, that makes all kinds of sense. And what an easy fix.
Yeah. And then that's on a, deeper brain level, where your brain is constantly mapping areas for danger.
Yeah.
And, one isn't really conscious of that. What then happens is, after some time, you actually lose faith in your ability to either fall asleep or stay asleep.
Yeah.
And then that causes sleep anxiety, almost like performance anxiety, which kind of further exacerbates that pathological cycle. And so, what sleeping tablet to use, it really depends. The other important thing to note with all of these sedatives, every single one of them has side effects.
Of course.
Okay. And so, it's also a way up of those side effects, what other medication they're on. So there's really a lot that goes into it, but you have to understand that it's always risk versus benefit when prescribing. And yes, in certain patients, they need the medication. The risk of not sleeping is greater than the side effects, but there's no silver bullet here. Most of them are going to cause next day grogginess, next day sedation, memory issues, mood changes, appetite changes. And so, one has to keep that in mind as well.
Sure.
Yeah.
Sure. Is there a particular point in our sleep cycle, whether it's REM or deep sleep, where is it that we dream? And why do we dream?
Yeah. So it's REM sleep, rapid eye movement sleep.
Okay.
And generally speaking, in the first part of your night, you might have a bit of REM, but the second part of your night is REM dominant. And if you look at the brain of somebody in REM, it looks very similar to somebody who's awake.
It's awake, yeah.
So if you look at the brain of someone who's in REM, it looks very similar to somebody who's awake. You also have flaccid muscle paralysis of most of your muscles. Obviously, vital and smooth muscles are still working, and that's so you don't act out your dreams, except for the eyes that move when you're in REM, hence the name rapid eye movement sleep. And, it's really important for memory consolidation, for emotional consolidation. And you can think about it like a safe space for your brain to process the previous day and previous events from an emotional perspective. And it's a safe space for you to work through, challenging and potentially painful, emotional kind of things that have happened previously.
Sure.
And so, for example, in people with PTSD, where they have noradrenaline that kind of intrudes upon REM, they have nightmares where you shouldn't have any noradrenaline. It should be a safe space to kind of consolidate things. And it's really important. Again, emotional regulation and consolidation, cognitive function, and memory. So short-term memory, that's where you take information from kind of RAM, so from the short term, and you kind of put it into your hard drive.
Yeah. How do you work with somebody who has recurrent nightmares?
So it very much depends. So are the nightmares because of trauma? Is it a child? Is it not a child? One of the biggest causes in adults for nightmares is obstructive sleep apnea.
Sure.
And specifically, what I'm seeing in females where you can have REM dominant obstructive sleep apnea. So when we look at a sleep study, we see that most of their apnea is happening during REM sleep, and that can trigger nightmares. A very cold temperature can trigger nightmares. Again, a nightmare here or there is absolutely fine, but if it's most nights, that is when you come and see us.
Okay, that is so interesting. So let's talk gadgets, because Oura rings, Ultrahuman rings, Whoop bands, Apple Watch, Garmin, everything is tracking our sleep nowadays, and they cannot possibly be as accurate as going into a clinic and getting a proper breakdown of your sleep health. So let's talk about the pros and cons of these gadgets, where they can be helpful, where they are absolutely not being helpful. In your opinion, where do you see, are they useful, firstly?
So I think, again, very, very much context dependent. So I think it's important to know, firstly, what they are good at and what they are not good at from a sleep perspective. So the gold standard of assessing and measuring sleep is what we call a polysomnogram. Okay, that is where you go into a facility, you have electrodes put over your head, the EEG electrodes, the eyes, on your chin. It's really a full thing. Sleep stages, so light sleep, deep sleep, and REM sleep, are classified on EEG leads.
Okay.
So unless your device has EEG leads, it's not going to be accurate in staging your sleep.
So it's assuming.
It's assuming. So it's inferring from movement, oxygen saturation, heart rate, all of those kinds of things. And every tech provider has got their own kind of black boxed algorithm that takes the data points that it collects and kind of infers sleep stages.
Okay.
So that's number one. Where it is good is, oxygen saturation, they're pretty good. Heart rate, they're pretty good. Heart rate variability, they're pretty good. But you have to understand the limitations, okay? And the saying, what gets measured gets managed.
Yes.
But if your measurement tool is inaccurate, then don't stress too much, because you might be trying to manage or over-optimize where it's really not needed.
It's not true.
It's not true.
Yeah.
And so night-to-night variability, we don't worry about. trends are more important. So what I recommend to people is look at your sleep data once a week. There is absolutely no use in looking at it every morning. You may wake up and subjectively feel great, okay, which means you've slept well.
Yes. How about you just introspect a little bit?
And again, from an evidence-based perspective, that is one of the best markers we have to measure sleep. So you wake up, you feel really good, and then you look at your data and you say, oh, it actually wasn't so great.
Oh, wow.
So what do you do with that? So I recommend looking at it every week.
Okay.
Again, what Dr. Bentley, what Alison always says is like, if someone comes to us and they're having like 0 REM sleep on a wearable for like the last few weeks or months, we would look at that.
Yeah.
So it's important to understand where they fit in. If you are passively just tracking your sleep, look at it once a week, once every 2 weeks if you feel great. If you're using it as almost like a objective scientific tool where you're going to say, right, I've got 3 weeks or a month of sleep data. What I'm going to do is for the next 2 weeks, I'm going to move my last cup of coffee from 4 p.m. to, let's say midday.
Okay.
I'm going to do that for the next 2 weeks. Let's see how it affects my sleep data. Then that's absolutely fine. But the problem with these devices is they can cause something called orthosomnia.
Yes.
Where effectively the more, it causes anxiety around sleep.
Right.
And because of that stress and performance anxiety around sleep, paradoxically, your sleep worsens.
Yeah.
And so you've got to kind of say to yourself, am I, quite an A-type, highly anxious person around these things?
Yeah.
Am I going to obsess over every night's, sleep data? I don't believe I have a sleep disorder or, it's been managed or whatever it is. In that case, use it every 2 weeks just to see. Know that your subjective daytime functioning is a lot more important than your wearable data. And I always say with these things, approach it with curiosity, not with anxiety. Meaning, if you are trying to optimize your sleep, just say, right, I'm going to try this. I'm just going to see what happens. I'm not obsessing over the outcome. And I've found that in working with patients where we work to approach it just with curiosity, it actually works to reduce the anxiety. So, and again, there's so much device-to-device variability. Someone could be wearing an Oura Ring and a Whoop, or an Oura Ring and whatever, and you would get something completely different.
Exactly.
I've had a patient come in where his watch showed oxygen desaturations. It showed heart rate increases after the oxygen desaturations, and I thought, this guy's got apnea. This is amazing. And turns out he didn't. So I'm glad he came in because he also snored. And so, creating more awareness around sleep. And again, you will get sleep disorders that people pick up on their watch. And that's great. So they definitely can be used in a useful way. I'm not saying at all that they're not useful. It's just being careful about how they are used and understanding their limitations.
Yeah, I think awareness is key. And a well-known medical aid provider undertook an enormous study. I think there were 100,000 or more people that they studied, looking at the quality of sleep. I'm not sure what devices they used or if they used proper clinical devices. And the outcomes were obvious. There were people drove better and they worked better, obviously, if they got enough sleep. But what they've gone and done is they have tied financial penalties to whether or not you sleep well. So they're going to pay for your Oura Ring, but if you don't get 8 hours of sleep a night, they are going to financially penalize you. And that flies in the face of the whole point of getting a good night's sleep, because now you've got this extra pressure and more orthosomnia, because now you're going to have to pay for something that should be helping you and not hindering.
Yeah.
So I think it's a bit of a backward way of doing it. I mean, you can be penalized for not going to the gym because it's your choice whether or not to exercise. But when it comes to something like sleep, what if you are highly stressed, have a newborn, are ill, for example? What if you can't breathe because you've got a cold, and they end up penalizing you because you have a cold?
Yeah.
And this is actually what's happening. I think that is highly, it's just not fair.
Yeah. Yeah. Or if somebody has a sleep disorder.
Yes.
And that they're unaware of it.
Exactly.
What happens then? Are they going to be penalized? And where do they go? So my other question in this whole thing is, okay, someone's not sleeping well. They're invested in their sleep.
Yeah.
What do they do? Where's the referral pathway in that?
Instead of penalizing them, rather refer them.
Correct.
To a clinic.
Yeah.
Try and help them before you financially cause trouble.
100%. You
Yeah.
know, sleep is almost the opposite of exercise. If we look at the you know, pillars of health, in that absolutely you push with exercise, right? If you try getting to bed and you hype yourself up and you say, right, I'm getting 8 hours of sleep tonight. I'm getting my 25% deep sleep, my 25%.
Yes, hit those targets, baby.
You're not sleeping that night, right? And so it's going to be an interesting kind of mass experiment to see what happens when people are obsessively chasing 7 nights of perfect sleep every night. And again, what happens to the people that have a sleep disorder? Because you must remember, if we add up all of the clinically significant sleep disorders in South Africa, it's over 25% of the population have a clinically significant sleep disorder. And a lot of people feel that's actually underreported.
Probably is.
Okay. So we're now putting this mass program on a population where we know 25% of them have a clinically significant sleep disorder. What's going to happen?
Yeah. This isn't looking good. Yeah. So what are the 1 or 2 or 3 things you and I could do, or somebody listening could do tonight to start being more aware of how to get good sleep?
Yeah, 100%. So it's unfortunately in sleep, it's not something that can be hacked.
Yeah.
Okay. There aren't any quick short-term fixes. Unfortunately, it's largely behavioral. The good news is that with small behavior changes, you can get incredible results and incredible improvement in your sleep. Okay. And so the 2 biggest things for me, the first is regularity. So going to bed at the same time and waking up in the morning at the same time is really important consistently. Understanding your chronotype and understanding, you know, what your sleep need is from a duration perspective. Once you've got that locked down, going to bed and waking up at the same time every day is really powerful. And people say, what about weekends? And I say, if you get that right, and a few of the other things we'll discuss, you won't need to sleep in on a weekend.
Sure.
Okay. So that regularity is really important. The second thing, which is so powerful. So, you know, people speak about all of these sleep supplements, right? So L-theanine, ashwagandha, magnesium glycinate, apigenin, and the list goes on and on and on. And I say, you know, in someone without a sleep disorder, if they take it, you know, and kind of overseen by a doctor and it works for them,
great,
beautiful, please go ahead. But there's no supplement that's indicated for a sleep disorder or for insomnia. Okay. And what I've found is, and what the research shows is so much more powerful than any type of supplement, is a wind down routine.
Yeah.
So I will give you the criteria. If you do a good wind down routine, you won't need a morning routine. Okay. That's my saying.
That's
okay.
clever.
Really. And so you have to understand, sleep is not an on-off switch in the brain. You don't go from awake to asleep immediately. It's a slow, gentle, fragile transition. And you need to guide that and as much as possible, right? And so, number 1, your wind down routine should be an hour before your sleep time. Number 2, it should not be in your bed. Okay.
Interesting, Matt.
Yes.
Yeah.
You don't want to do anything wakeful in your bed.
Okay.
So they say, you know, the 3 S's for what you can do in your bed: sleep, sex, and sickness. Okay. I even say for sickness, you can still be on the couch for that. Okay.
Yeah, true.
Yeah. And so wind down routine an hour before bed outside your bedroom. So find a nice little area and you make it as dark as possible, preferably all the lights off.
Okay.
And you do something that is relaxing but distracting. Okay. Meaning you're not watching Piers Morgan Uncensored on YouTube.
Yes.
Okay. But you're doing something where you are distracted enough that you are not ruminating about work and stress and you don't kind of spiral, but something that's relaxing. So if it's a book, have a small nightlight with ambient light being in the dark and have it be fiction. Don't have it be, 10 steps to becoming a billionaire or how to not get divorced, those kinds of, triggering.
Yeah.
And you wind down for that hour and you relax. And I promise you, if you do that, even just, tonight, you're going to feel really, really, really sleepy.
Yes.
And it's going to induce sleepiness that most people haven't experienced since they were a child.
Yes, I can imagine.
What we do is we work, we do everything. Then we get into bed and then we go on social media, right? Yeah. The pre-sleep doom scrolling.
Yes. Worst thing.
And what the research has shown, so there was a big thing about blue light. Yes, it's important, but it's not as important as the content you are consuming.
Yeah.
Okay? And so what do people do? They get into bed with all the lights on, or they have their phone here and they're on TikTok, which is highly arousing. It's causing dopamine.
Yeah.
It's causing arousal.
Right.
And then they do that for however long, put their phone away, and then go like that and expect to sleep.
And the images are going in your head.
Yeah.
Even with your eyes closed.
Yeah. and then they say, it can take up to an hour to sleep. So I'm like, that's your wind down routine. So for me, it's regularity and it's routine. So that wind down routine is super powerful. And then again, if you want to optimize further, some morning sunlight from a circadian perspective.
Yeah.
Once we know there's no medical condition, no mental health condition, sleep disorders have been sorted, just from an optimization perspective, that regularity and that wind down routine.
What are your thoughts on the morning routine? So what I do in the morning will translate into how well I sleep at night with the early morning sunlight. What are your thoughts around that?
It's brilliant. So morning sunlight is a very powerful signal, okay? And it hits a part of your brain through some pathways called the suprachiasmatic nucleus, which in your brain is your master clock, okay? And that runs on about 24 hours. Some studies have shown a bit more. It doesn't really matter. It's your internal 24-hour clock, okay? And it understands when is daytime and when is nighttime naturally, okay? So you just intrinsically have that clock. And that then coordinates a whole bunch of processes when cortisol is released, when melatonin is released, body temperature, all of those types of things. But with the circadian rhythm, there are what's called in sleep medicine Zeitgebers, which is German for timekeepers. And those are external stimuli that sometimes disrupt our sleep, but we can use to actually improve it, like morning sunlight. Okay, it's a big Zeitgeber, like alarms, like wind down routines, like switching the lights off before your wind down routine. And so where it comes unstuck is, if you're having lots of late nights with lots of blue light, those are doing stimulating things like work or watching, stressful things on the news, that can disrupt your circadian rhythm as being kind of negative Zeitgebers. But that morning sunlight, evening darkness, wind down routine are really powerful positive Zeitgebers that help lock in your circadian rhythm.
What I found as well with people is with night cravings, if you get that early morning exposure to light, the cravings for sweet things at night also diminishes. And I think that might also have to do with the circadian rhythm.
Yeah, it's really interesting. And eating. So, having, good protein, good fats, and low glycemic carbohydrates. So, in the two things with eating, from a sleep perspective is timing. So you want to have your last meal about 2 to 3 hours before bed. And that's got to do with heart rate, body temperature, and reflux.
Yeah.
Okay.
Big time.
Yeah. But now, if you haven't eaten the whole day and you've had one meal, that's when you're going to start craving. And then to also have low glycemic carbs. So you don't want these massive sugar and insulin spikes and dips because, again, if you wake up at around 4 a.m., middle of the night type thing, it's not common that it's these sugar dips and insulin dips, but it can be hypoglycemia, low blood sugar. So you want to kind of have as stable blood sugar as possible.
There's one thing we haven't touched on, which somebody is going to comment and say, you didn't talk about caffeine. What are your thoughts about caffeine and how late in the day should we be having caffeine?
Yeah. So caffeine is great. Okay. No issues with caffeine. So very quickly, how does caffeine actually work?
Yes.
So when you are awake, your brain uses energy. A byproduct of that energy metabolism is something called adenosine.
Right.
It's like the exhaust fumes of a car.
Yeah.
And the longer you're awake during the day, the more adenosine builds up.
Right.
It's just a byproduct of that metabolism.
Energy cycle. Right.
Adenosine hits adenosine receptors, and the more adenosine receptors that are saturated, the sleepier you feel.
Sure.
Okay. And it ultimately reaches a crescendo, and then you feel really sleepy and you fall asleep. That sleep pressure drives deep sleep, and it's during deep sleep where that adenosine gets cleared away until you have no more sleep pressure and you wake up. Caffeine just blocks adenosine receptors, and so it gives the illusion of not feeling sleepy. Okay. So it's really good. It's like 11 a.m., you're like feeling a little bit and you have that nice cup of coffee. Brilliant. You have to understand the average half-life of caffeine is about 6 hours.
Yes.
So if you like cappuccinos, generally they all have a double espresso, and you have one at 4 p.m. Okay, you've got to understand it's the equivalent of having a single espresso at 10 p.m.
Right.
Okay. So my rule generally is no caffeine after midday, so about 12:1.
Yeah, that's the rule.
Because why? You want maximal adenosine receptor saturation come bedtime.
Yeah.
That's going to help you fall asleep easier and stay asleep easier. And so caffeine, after that can definitely affect sleep. The other thing is, caffeine is somewhat addictive, but if you are, really seriously needing caffeine to function, that is also indicative that
something's wrong.
Something is wrong.
Yeah.
Yes, I'd really like a cup of coffee in the morning, but I'm not going to be rendered dysfunctional if I don't have it.
Exactly.
And so enjoy your coffee, have it, but stick to the cutoff being about midday.
Common sense.
Yeah.
What is the one thing you'd like people to leave people with after this conversation, just to think about when they go to sleep tonight?
I want you to think about absolutely nothing and just relax.
Love that.
Because sleep is something that happens to you. It's not something that you do. And the more you try and chase sleep, the further away it gets. And so when you get into bed tonight, don't worry, don't force it. Let your brain and body do what it's programmed to do. Stop thinking about stressful things. Allow yourself, give yourself permission to switch off. Even when you wind down, say, this is my time. Thinking about work or anything is not going to be productive at this stage. Make the conscious decision to let go and for you to just relax and think about random things. We sometimes talk about cognitive shuffling, so the audience can look that up, where it's a whole exercise. You can do breathing exercise, but just relax and don't worry. Sleep will come to you when the conditions are right. And the conditions needed for sleep, we've discussed a lot of them, is to just relax. So the quicker you don't force it, the quicker you let go, the quicker you will fall asleep.
That's profound and wise words. Dr. Benji, thank you so much. I have learned so much today. Thank
Brilliant.
you so much.
Thank you so much for having me.
My pleasure.